Hello, everybody. I'm Stephanie Jordan. I'm the local food program manager at Sustainable Solano, and I will be your friendly moderator today. You have arrived at the February meeting of the Solano Local Food System Alliance. Their mission is to support a environmentally regenerative, economically viable, and socially just local food system here in Solano County. They meet quarterly, and these quarterly meetings are dedicated to have educational topics presented and also to cover a little bit of business. So I am here welcoming you from Cathryn and Miwok lands, which is now called Solano County. And we want to honor and respect the indigenous tribes who have stewarded these lands for generations. California has over 200 native tribes, and my colleague Allison will be posting in the chat a native lands map so that you can learn more about where you live and also share this knowledge with others. All right, we have kind of a packed meeting here today. I just want to give you a brief overview of how it's going to go. So the first hour, possibly hour plus, will be dedicated to hearing from our speakers, and we have 4 of them who I will be introducing shortly. If you have any questions, you are welcome to post them in the chat and or raise your hand, and then we will allow you to unmute once we get to the Q&A portion. We may also kind of pause after a couple of presenters have spoken so that we can catch up a little bit and ask any immediate questions as well. I also advise if you can turn on your Zoom speaker view, sometimes that's a little easier to see as we go along. So we chose this topic really briefly. There's funding, there are opportunities, and there is a need for medically tailored meals. And we also wanted to have a better understanding of how medically tailored meals fit in to the larger local food system picture. And that's all I'm really going to say because our speakers really have a lot more to say about that. So I will then now introduce who we have. We have Cathryn Couch, who is the CEO of Ceres Community Project based in Sebastopol. She will be giving a pretty thorough overview of medically tailored meals and why it's important and health benefits, how the funding works, etc. Allison will be dropping also into the chat some links to the websites of our speakers so that you can investigate that further. We also have Paul Hepfer, who is the CEO of Project Open Hand. Project Open Hand's mission is to nourish and engage their community by providing nutritious meals with love to the sick and the elderly. And so he will be sharing some experiences from his on-the-ground work in the Bay Area. We have Norma Lisenko, who is the Chief Financial Officer of Innovative Health Solutions, and IHS is based here in Solano County. She will be speaking about a pilot that they ran here in the county. And then finally, Lauren Gucik is one of our own program managers, and she will be briefly speaking about another pilot that we ran, which engaged some youth in larger batch cooking, which could be integrated into the medically tailored meal picture. All right, with that, look at that, I did it in like 4 minutes. I'm going to turn it over to Cathryn and let her dive into this medically tailored meal topic.
Great. I'll share slides in just a second, but first I just want to say that Paul and I are both representing our agencies, but more importantly, representing the California Food as Medicine Coalition and the National Food as Medicine Coalition, which we're both on the board of. And our work really sits on the shoulders of the work of many organizations, starting with the AIDS HIV crisis, and Project Open Hand was one of those early ones. And just as background, in the late 80s, when there was this crisis and people were dying of AIDS, many of them with their families not supporting them, people stood up in communities around the country and started making meals. And one of the things that they learned very, very early on is that when people had good nutrition, their viral loads actually went down and they were less likely to transmit the AIDS virus. And so in 1990, when the federal government funded the Ryan White Act, which is still the federal funding stream for AIDS HIV, they included home delivered meals as a covered benefit in Ryan White. And that was the first time and the only time until 2020 that food support was actually considered a healthcare benefit. And those agencies over the last 40 years have they've expanded dramatically the number of people they're serving, began to build the research evidence around medically tailored meals, came up with the term medically tailored meals, defined the definition for medically tailored meals, and created the nutrition guidelines for medically tailored meals. So I think it's just really important to understand where this work has come from, and that the agencies that are part of what we call FEMIC, including Ceres and Project Open Hand, have really defined this field and continue to lead it. And so we're gonna talk about all of that, and then we're gonna talk about what's happening in California and what's been happening within Medicaid nationally, and how that's now showing up in California, and where there's now healthcare dollars supporting this work in many different ways, but also in Medicaid. And we'll talk a little bit about how that benefit structure works, about what it takes to be able to contract with a healthcare organization to get that funding stream, which is pretty extensive. And I'm going to take the lead, and then Paul will just chime in. And I'll say that it was hard to prepare this presentation because I'm really unaware of how much of this is new to all of you. So I really encourage people. I think it's probably better that we don't go through the whole presentation, then you ask questions. But please feel free to either put a question in the chat. I assume Allison or Stephanie will be watching that, or use the raised hand feature and just stop, because it's not going to be valuable to you guys if we just power over things where you don't have the information you need. So if you're going to really get out of this the information that you need to think about how this is what the implications are for Solano, then let's just make sure that we're moving at a pace that really works for everyone. So let me share my screen. I think I'm going to do this from the beginning. Did that work? Okay, good. I never quite know. I set it up ahead of time. So, I intentionally, I did this all got done before Paul was joining. So I apologize that he's not on here, but I do have the FEMIC coalitions and I think I have CalFEMIC on here too, but those really, you can go to our websites, but I would encourage you to go to CalFEMIC, which is spelled incorrectly on here, and the FEMIC Coalition website, which have lots of information about the intervention, lots of information about the research supporting it, and all of that good stuff. So I know we're all familiar with this, but I really think that we cannot look at these statistics enough. There's a reason why we are talking about food and health. We know, and I don't have the slide in, but we know that food insecurity by itself is costing us at least $77 billion a year in healthcare costs in this country. Diet-related illness is now the #1 cause of mortality in the United States. That is really tragic to be able to say out loud. We are now eating ourselves sick. We can eat ourselves well, but it's not the same food. And it's a very different thing. 85% of healthcare spending now goes to chronic disease, most of which is preventable with better diets and lifestyle changes. And 3 out of 4 young people no longer qualify for military service because of poor health. We have an epidemic of childhood obesity. The American College of Pediatrics just came out with new guidelines. What I found really troubling is that they're now talking about obesity as a genetic problem. But the reality is we didn't have that genetic problem 50 years ago. So what has changed that is activating that gene and creating the epidemic of obesity that we have? They're talking now about bariatric surgery for kids 12 and older, putting kids as young as 5 on medication to lose weight, but we're not actually getting back to the root of the problem, and probably need to be talking about nutrition during conception and all kinds of other things. But we can't not look at these from my perspective. So there are many versions of this. We talk a lot in the Food as Medicine Coalition about the prevention treatment continuum. The reality is food matters for everyone, right? It starts with investments in SNAP, WIC, school lunch, all of those different things. We have to do a much better job in those fundamental food programs. Then when you start to move up, we're starting to look at things like produce prescriptions and voucher programs for people who've just been diagnosed with diabetes, or people who are pre-diabetic, or families that have kids with obesity, where there's still the ability to shop and cook, right? That's not the limitation, but people just need access to healthier food. And then you get into medically tailored grocery programs where people really need a much more limited set of food and more control over what they're eating, but they can cook those foods for themselves. And then at the top of the pyramid is medically tailored meals. For a long time within the Food is Medicine Coalition, the phrase was that we serve people who are too sick to shop and cook for themselves. At Ceres, we don't use that definition. We use a broader definition. We say that people who are too sick to shop and cook, or for whom their medical diet is so complex that it's difficult for them to manage to it, or they have the inability to actually purchase the kinds of foods that they need. So there's a kind of a host of things. And Paul, I'm going to stop and see if you want to chime in and add any comment there.
No, you nailed it all so far. I'll join you next time.
Okay, no worries. So what is a medically tailored meal? And this is the definition developed by FIMIC. So medically tailored meals are delivered to individuals living with chronic and serious illness through a referral from a medical professional or healthcare plan. Meal plans are tailored to the medical needs of the recipient by a registered dietitian and are designed to improve health outcomes, lower cost of care, and I would say increase quality of life, but patient satisfaction. All meals are healthy and low in sodium and saturated fat, but they may be tailored beyond that. For example, people with chronic kidney disease or end-stage renal disease need very different kinds of meals. People who are suffering from malnutrition may need different kinds of meals. Gestational diabetes requires a much more complex management of carbs than someone who's just got type 2 diabetes. So there's a lot of complexity in that. I'll also add that we deal with all kinds of food allergies as well. We could deal with cultural or religious restrictions on food. All of those become part of it. It includes home delivered medically tailored meals plus RDN support, which includes maybe nutrition risk assessment, referral to an RDN for one-on-one nutritional support, and RDN oversight of what the folks are actually getting. I'm gonna pause, Paul.
Yeah, one point I wanted to add on this, and we will be touching on more of this throughout the presentation. The term medically tailored meals, because it hasn't been trademarked or registered or copyrighted, you're going to see it all over the country now. I recently was in DC at a presentation, and there were at least 4 for-profit vendors in the audience who are using the term now. And you could honestly be serving pizza and put arugula on it and call yourself a medically tailored meal. And it's like the wild, wild west in some cases. And it's really a big concern of ours. And that's why the coalition's worked on our own standards, and we monitor ourselves. And we've been judicious about partnering with people to make sure that we're adhering to those standards.
Yeah. And nationally, we have accreditation standards, which we're now being rolled out, that are very, very rigorous around quality assurance standards, around the nutrition guidelines and all of that. And the FIMIC, the National Food is Medicine Coalition, also has an accelerator program, which is a year-long program training organizations who are already doing food work, like some of the big food banks and others, to become medically tailored meal providers. So it's complicated, and lots of people, because they see those healthcare dollars out there, are claiming that they do what we do, and it's a very different thing for the most part. So here's just a little bit of the research. There's now, I'll just mention, if those of you are not familiar, but the Aspen Institute about a year ago came out with did an 18-month process and came out with a national research action plan around food as medicine, which really summarized a lot of the peer-reviewed published data on medically tailored meals, groceries, and produce RX, and has a beautiful section around doing community-led research work as well, which is really great. But this is a summary of published research primarily by FIMIC agencies, and there's at least 11 other studies that are underway, including some NIH studies, some preliminary ones and some larger scale ones. So basically what we're seeing kind of in aggregate is somewhere around a 16 or 20% net savings on the healthcare cost side after the cost of the medically tailored meal intervention. And this is across a pretty broad set of patient populations, but primarily low income, I will say, because most of our agencies serve primarily very low income people. About a 50% reduction in hospitalizations, 70% reduction in ED visits, much more likely to be discharged to home, shorter hospital stays, an increase in medication adherence, and 72% reduction in admission to skilled nursing facilities. And then I think, interestingly, we're seeing increasingly in the field this conversation about the impact on mental health, but certainly decreased days in which mental health were interfering with quality of life. So a pretty broad array of benefits. And I'll just say, just talking about the research, that one of the things that we are balancing in the field is that we're going to a pretty big effort to say to health plans and providers, you're going to save money if you do this thing. That is not the standard for most things that get rolled out in healthcare. Most pharmaceuticals, as long as you show you're making a difference for the patient, that the patient is going to have better quality of life or feel better or have better health outcome, you meet that standard. And so we're actually holding ourselves to a much higher standard in the way that we're approaching this than most other healthcare interventions are held to. And I think we have to be careful there because we don't, it's a challenging conversation to have. I will also add, there's a new study that came out from the Tufts Friedman School of Nutrition, which modeled what would happen if we rolled out medically tailored meals to all of the population in the country who could benefit from them. And it was a set of conditions: diabetes, congestive heart failure, cardiac arrest, other heart disease, emphysema, stroke, various forms of cancer, chronic kidney disease. And basically what they showed was that 6.3 million Americans would qualify. If they all received the intervention, we would avoid 1.6 million hospitalizations and save somewhere between $14 and $28 billion a year in healthcare costs in year one. So this is a really important study. One of the challenges, we'll probably talk about it later, but there's a bill that we've introduced with Congressman McGovern federally to do a Medicare pilot of medically tailored meals in the Medicare program. And because we're talking, the Congressional Budget Office doesn't know how to score cost savings. They only score a bill based on costs. And this is a fundamental problem in making federal investment decisions, because everyone continually talks about costs instead of talking about investments that will actually save significant costs over time. So we're actually not at a federal level making decisions in the right way, but this is a very important study for shifting the understanding of investment versus cost savings and showing the broad benefit of medically tailored meals. So who benefits? I mean, there's a broad set of things, but there's some diagnoses here on the left. It's not exhaustive. And we think about it in terms of, people who are food and nutrition insecure, socioeconomically disadvantaged, often because they can't afford the quality of food that they need, may have mobility challenges, and then often one or more complex or chronic or acute illnesses. So most of the people that we serve are not dealing with just one illness. They're actually dealing with multiple illnesses. And this is why, just to say, it's so important to get a medical referral form. So a client may call up and say, I've just been diagnosed with cancer, can you help me? But if we don't have a medical referral form, we don't also know that they have high blood pressure, or we don't also know that they've got diabetes. And so in order to make sure that we're actually doing no harm, we need to understand that full medical picture for our clients. Paul, anything you want to add on diagnoses? And
well, and on that point about getting the referral from the provider, I think one area that the members of our coalition that have been doing this work for actually 30 years, maybe 37 years, because of our original work in HIV, we kind of got out of the gate early, knowing that was a requirement. 30 years ago, we were tracking viral loads and CD4 counts and things like that. So it wasn't a huge lift for us in the more recent years, in the last 5 or 6 years, to start looking at A1Cs and blood pressures and some other things. But that's, again, to Cathryn's point at the beginning, that's really what sets coalition members, national and California, apart from one of the things from other food security providers, is because we do have that experience and that expertise and that focus. But in some cases in the medical community, that's a switch for them. If they're not used to making referrals for a food program, they often say, well, why do you need a background? Why do you need the labs? Why do you need this? And then we have to take the time to explain that we're not just providing food bank related groceries or Meals on Wheels type meal. We're actually providing a medical intervention, and here's why, and then we can have that conversation. It's definitely improved tremendously in the last three to 4 years, but before that, it was very difficult for us to get complete patient or client referrals.
Yeah. I'm going to say one more thing, and then I want to stop for a second and see if there's questions. So among Ceres clients, 85% are living on less than $25,000 a year. That's 200% of the federal poverty level. About 27% have cancer, 50% have diabetes, cardiovascular disease, congestive heart failure, COPD, kind of chronic diseases. And the rest could be MS. There's a whole kind of host of other illnesses that our patients might have. And then I think interestingly to say is that 42% of our clients are younger than 60 and don't qualify for service from any other provider. So they're not going to get served by a Meals on Wheels provider, even if that Meals on Wheels provider could actually serve the quality of food that they need. And so we have cancer clients that are in their 20s. We have, young single moms that are going through breast cancer. So whole host of clients that most people don't think about when they think about food support. So the California Food as Medicine Coalition came together in 2017 when we had the opportunity to ask the state for $6 million to fund the first in the nation statewide pilot of medically tailored meals. And we pulled together agencies, Paul and I, and agencies in Southern California, Project Angel Food in LA, Mama's Kitchen in San Diego, the Health Trust in Santa Clara, and then Food for Thought here in Sonoma County, which is primarily a grocery provider. And we came together and we were successful, surprisingly successful, in getting the state to give us this money. And, it was a really big deal. And I think when we realized that we had gotten the funding, first, we were like, well, we better make sure that this thing works. But secondly, we realized that we got a lot of press, and we realized there was a really important opportunity to educate elected officials, providers, health plans across the state about medically tailored meals and about the role that they could play in improving health outcomes. We were lucky enough to get some additional funding from the Archstone Foundation. We were able to hire a project director, and that's when CalFIMIC really kind of came together and started to lead the work in California. And we did a couple of statewide symposiums. We began to kind of really lead educating. And what's interesting now is that so many more people understand this work and are champions of it. So we got the $6 million. This is a pilot that ended in December 2021. The data is being evaluated by a national health evaluation firm called Mathematica. We hope to have the data public in the next few months. We ended up providing about 1,200 Medicaid. So the state, the Department of Healthcare Services, which oversees Medicaid in California, oversaw the study, and we had some control over what we did, and they had some control too. So they picked congestive heart failure as the target population. For all of you to know, that is the population that has the highest readmission rate to the hospital. And so one of the things that happened with the Affordable Care Act is hospitals do not get reimbursed for what are called unplanned readmissions. So there's a strong incentive to reduce unplanned readmissions among different populations, and congestive heart failure patients have the highest readmission rate. So there is an incentive to really look at that population. We provided 21 meals a week for 12 weeks, plus medical nutrition therapy by RDNs. We had about 1,168 participants. 61% completed the full intervention. That is not a bad number, just to say we looked at this as what's called a natural experiment. So Medicaid population is not extremely stable. There are lots of reasons why people will drop out of an intervention, but we had 61% complete the full intervention. And the preliminary data was very positive. So because we had done this work, because we had gotten this funding for the state pilot, because we started to build a relationship with DHCS, this is part of what led medically tailored meals to be included in CalAIM, which I'll talk about in a minute. So this is the current CalFMIC coalition. You can see the participants, there's 8 agencies. We cover about, I'm not going to probably get this right, 14 or 16 counties, but about 75% of the Medicaid population in the state of California, because we are in many of the very populated counties. And we have a executive director for the coalition, and we work together across a set of things. So collectively, our coalition serves about 4.5 million meals a year to about 20,000 people. We nearly doubled our capacity in 2020 in response to the pandemic. Those numbers have not gone down. Ceres actually has gone up by 2.5 times what we were in 2019. We are primarily serving a low-income population, 52% people of color. See, there's even with the coalition, about half are over 60 and half are under 60. So it is not primarily a senior population, and 52% below the poverty line. Paul, you want to add anything here?
Just briefly on the pilot that Mathematica is getting ready to release. We can't talk about the results yet, and it's embargoed until it's actually published. We are able to say we're encouraged by what we expect to be released in the next 2 months.
Yeah,
and we'll keep you all posted on that.
So I'm gonna I'm gonna show one more slide before I talk about Medicaid. So these are a couple of other small studies. So after we got the state funding and we launched the state pilot, one of the other health plans, Central California Alliance for Health, did their own pilot in Santa Cruz with about 500 of their patients that had either congestive heart failure or chronic obstructive pulmonary disease. Lots of health acronyms on this slide. And they provided the same intervention we were providing. So I think it was 14 meals a week for 12 weeks for patients who were being discharged from the hospital. And what they found was that they saved $3.60 for every dollar they spent. And their cost savings was about $532 per member per month over their 9-month evaluation period. They, once they got these results, they made this a permanent benefit in their health plan ahead of Department of Healthcare Services rolling out the state benefit. And part of what CalFMIC has done is to help spread this kind of information among providers and health plans. So we're encouraging other health plans to step forward and to begin to do this work. There was also, Paul, do you want to talk about the Anthem pilot? Because you were directly involved in that. Yeah,
and that was, one thing we learned prior to the in lieu of, so I keep saying in lieu of service, prior to CalAIM, there's other healthcare payers that had came out the door earlier to contract with various providers for medically tailored meals. Anthem is one. A national health plan approached us and said, look, we want to do this in Los Angeles, Santa Clara County, Alameda County, and San Francisco County. And those were some of the counties where they had pretty big populations of some people that were had some various challenges with their chronic health issues, but they didn't want multiple contracts. Health plans work a little different. This is a national health plan. So Project Open Hand served as a central contracting agency, and then we subcontracted with our partners in Los Angeles and San Jose area, and then we served 2 counties. They had Anthem had another vendor in the Central Valley that we weren't able to reach at the time, a for-profit partner. And since CalAIM came in place and this pilot ended 4 years ago, they decided to continue with the Bay Area and the Los Angeles group. We were able to provide the RD counseling and provide a more, I guess, a warm, localized resource than the Central Valley vendor that they were choosing at the time. So we also had a similar project with Northern California Kaiser that Cathryn and I both worked on. It was a 1,000-person research study that's now published, and you can review the results of that. So some of these health plans were, even before CalAIM was in place, looking at providing this sort of service. CalAIM encouraged the local managed care organizations to do the same.
Yeah. And I think I'm not going to switch the slide yet because it gets very down in the weeds about the current benefit. But just to step back, one of the things, and I apologize, I didn't put this slide in, but one of the things that's driving all of this is that over the last 20 years, there's been the general realization that only about 20% of our health is impacted by what happens in clinical care. And so about 30% is impacted by our lifestyle choices. I always say that's the good news and the bad news, right? The things that you eating, exercise, stress management, sleep, alcohol, drug use, etc. But 40% is impacted by the limitations on people's ability to make healthy choices. That's what's called the social determinants of health. So things like poverty, not having a safe place to exercise, food insecurity, all of those social factors are the biggest driver of health outcomes, far bigger than what happens in clinical care. That realization has really driven health plans around the country over the past 10 years to start to look differently at their investments. And, I was at a presentation, and it was 3 or 4 years ago at the Root Cause Coalition, where Humana was talking about, they're a big health insurer in the Southeast, that they had started to realize that emergency department visits among their population went up at the end of the month. That happens because people run out of food, and there are various consequences of that. And so they started to look at developing a food security intervention as opposed to paying for those emergency department costs. That aha moment has happened across the Center for Medicaid Services federally. It's happened at DHCS. It's happened among health plans. And so that is what's driving this whole kind of approach to expanding who the partners are that can be funded and the kinds of interventions that are funded under healthcare. So the other important thing to understand is that the Affordable Care Act provided an opportunity. So Medicaid is overseen by the federal government. It's a state federal government share. Every state has to follow basic Medicaid guidelines. But under the Affordable Care Act, states are allowed to innovate in their Medicaid plan by applying to the federal government for what's called a waiver, for a 5-year waiver. California has been doing that for a while. And the most recent waiver, which is called CalAIM, includes a couple of a multiple number of really big innovations that the state is going to roll out. But one of them is what they're calling community supports. And that is a way of funding non-traditional, non-clinical services within Medicaid. And that's what the next slide is about. So this is, there's a benefit structure in Medicaid called in lieu of services. And in lieu of services allows states to fund alternative services or settings, number I here, that are medically appropriate and cost-effective substitutes for covered services or approved services under the existing state plan. So my example for this is the state under this benefit could provide meals to someone at discharge from the hospital because there is evidence that it will prevent a readmission, and paying for a readmission is something that the state has to pay for under the Medicaid plan. So this is it's a weird structure, but basically what it means is that services need to be medically appropriate, and they need to be cost effective and or cost neutral against services that the plan would have been providing anyway. So when California rolled out CalAIM, they identified 14 services that under this structure that they were going to make available to plans to offer to their members and to pay for under the plan structure. So There's many of them are housing related, so housing deposits, there's some caregiver support, there's some other things, but medically tailored meals and medically supportive foods was one of them. So the way the benefit reads is home delivered meals at discharge from a hospital or skilled nursing facility, medically tailored meals delivered to members at home that need unique dietary needs for their medical conditions, or medically supported food and nutrition services, including groceries, healthy food vouchers, and food pharmacies. It's all very loosely defined. There's nutrition consults. I'll just say the grocery benefit that doesn't define how many meals are in that. It's all very, very loose. How it works is that the various plans contract directly with medically tailored meal providers. The plan can refer their members to the provider, or the provider can receive referrals, submit the referral to the plan for a treatment authorization request, then provide the services, submit claims for payment, and then receive those. This is a very important thing. The plans can actually add new services so the plans do not have to offer any of these benefits, and no member has to accept the benefit if it's offered. The plans can add new community service benefits every 6 months, and they could drop a benefit every 12 months. So I'm going to talk in a minute, Paul and I are going to talk about what it's taken to be able to do claims billing and contract with the plan, which has been a very significant lift for all of us. And literally the plans we're contracting with in the next year could say, we're not going to offer, I don't think it's going to happen, but we're not going to offer medically tailored meals anymore. And then all of that investment we put in is actually not available to us anymore. So there's a lot of risk. And I'm involved in a CBO group that's giving feedback to DHCS. And this is one of the things we're talking about, that there is a significant amount of risk for CBOs to enter this marketplace. It is a really big lift. Plans, my latest thing has been, there's a lot of talk about needing technical assistance for CBOs. And one of my lines is the plans need technical assistance because most of them don't know how to use this benefit. And they're making it up as they go along based on our guidance primarily. But there's a lot, it all sounds good, but it's a lot more complicated than it looks like. So I just have 2 more slides. So what's involved in contracting? You need what's called a national NPI number. You need to be HIPAA compliant, which means you have systems in place to manage the privacy of patient information, including in your IT systems. You need the ability to safely and securely track and report client data and services provided, including the date they were provided, how many, all that. You need the ability to submit and track approvals for treatment authorizations, to submit and manage claims. And that all underlies a significant IT infrastructure that Paul and I already had in place, and both of us have spent over in the 6-figure range in order to be able to move into claims billing. So Paul, please chime in. I know you have things to say about this one.
Yeah, and like I mentioned again, when we started doing some of the work with Anthem and Blue Shield for another similar process, reviewing the contracts that's involved to work with national large health plans was very intense for us. We had to look at things, we had to hire an outside consultant to do penetration and vulnerability testing of our IT security. Cathryn mentioned 6 figures. Project Open Hand, we cover 3 different counties. We've invested close to $500,000 in the last 2 years just to be ready for some of this, and to build on what we already had in place too. And to be going on, I don't want to rain on anyone's excitement here, but we haven't seen the volume of revenue even on the horizon that's going to help make up for this in the next few years. I'm betting on the long run that in the next 10, this will make sense for us, but it hasn't panned out yet. And thank goodness that we had some infrastructure support to be able to do this, or we wouldn't be looking at doing it in all the counties we serve, that's for sure.
And Paul's agency is already doing over 1 million meals a year, and we do 200,000. And so, and we already had a relationship with DHCS. I'm on the board of the health plan that I'm contracted with. We already had significant IT infrastructure. So for us, we added 2 new staff positions. We had significant investment in IT support, but also it took us, we contracted with the plan a year ago in December. It took us until May to have the pieces built out in partnership with them that allowed us to submit our first 10 treatment authorization requests. It took us 5 months to get those first 10 people through their system and those claims billed. And then we sat down with them and said, we cannot scale based on this. And we pressed them to kind of figure some things out with us. So it is not a small lift. And I just think people need to recognize that. I'll just say, frankly, having founded an organization and built it from the ground up, it's a lot easier to raise philanthropic dollars than it is to do this. Now, for us, and adding on to what Paul said, for us, we see this as our mission work. We believe that food should be covered by healthcare, and we are doing this work because we believe it's important to help lead the field. And if we don't take the risk, nobody is going to take the risk, right? So I think Paul would agree with that. So we look at it from both from the long-term sustainability potential for our organization, but also because it's important that someone steps forward and starts working directly with the plan and paves the path for others down the road.
And we have a lobby firm in Washington, D.C. and a lobbyist in Sacramento that we've charged with continuing to push CMS to expand this beyond just what CalAIM is. And so we want to make sure that we're ready if and when that does happen. So we do believe that it will happen. For our sector, there's just a long way to go to get there.
Yeah. So I have one more slide, and then I'll stop sharing, and we can open for questions. So this is, at least very recently, was kind of the state of things in California. So 18 of 21 plans are offering the meal food benefit. The plans that had, as Paul and I talked about, had previous experience with doing food pilots are moving much more quickly. It's a little bit like the Wild West out there. So every plan is providing the benefit for a different population with different eligibility requirements for who gets it. So there's not a lot of guidance here. Now, DHCS has shared with me that they are likely to narrow the guidance as they get more data. And there's a lot of parts of the state where we do not yet have capacity to deliver meals, and plans are really stuck with out-of-state for-profit providers in order to provide this benefit to their members. And it's one of the things that, and partly because I work with partnership as you guys do in Solano, and partnership covers 14 counties and will be covering 24 counties by 2024, all of Northern California. A lot of that is extremely rural. And I'm very committed to making sure that the quality of food that we do at Ceres is available to patients across that geography, because otherwise they're getting really crap food that is not the quality that Paul and I believe in. I'll say that reimbursement rates do not fully cover costs within CalAIM. It varies by plan, but it's definitely does not cover the administrative burden of actually contracting with a plan and managing the TAR process or the claims billing process. It was designed to just cover the service benefit. Hopefully DHCS is going to look at that. It's very difficult to scale this benefit if you're not getting full cost coverage. So if I'm gonna take on Mendocino County or Trinity County, I've got to raise philanthropic dollars to cover the gap, and that's very, very difficult to do. This is not quite true. It's unclear how success is being evaluated. I was very concerned for a while about this idea that there needed to be cost neutrality, that this benefit somehow needed to demonstrate cost neutrality with other services. CMS has a very broad way that they're looking at that now. It's in aggregate over time. I'm less concerned about this than I used to be. And then I think really importantly, we need to align around a vision for what we want this to look like in our state 5, 10, 15 years from now. Right now, there's this tendency for plans to go to the low cost, easy solution, which in some cases are these out-of-state providers. There's a there's a risk that dollars will go out of the state instead of being invested in community capacity and community resiliency. And that's really what we want to see. And this is a big part of what I'm raising in these conversations with DHCS, is there are risks involved with the way that it's set up right now. And we need to address those risks really quickly if we want smaller CBOs, rural CBOs, BIPOC-led CBOs to build capacity across the state, and make sure that we're really building a resilient community that's able to solve these problems kind of in everywhere, not just in the big cities. Paul, anything you want to add before I?
No, that's great.
So I hope that answered the questions you guys wanted answered. But I think it is what I tried to do is think about to give you a foundation and a really kind of comprehensive way of understanding the moment we're in, the way I think about it, the moment we're in both the risks and opportunities of that moment. So let's just open it. I don't know. I'll turn back to you, Stephanie, to see like whether we want to go with questions or.
Sure. Yeah, does anybody have immediate questions? Feel free to do a raised hand or drop something in the chat. That was a lot of information. Does anybody have any clarifying questions?
Yeah, go for it, Lauren.
Hi, I just first off want to say thank you both so much for being here today and bringing your wealth of experience and knowledge in this, for lack of a better word, industry, really, which is like an industry that's so connected to people. But I think my question is that relationship between like the CBO and the funder. It's like, what has been your development on that level with
the health plans?
Yes.
So I'll just say, so health plans are under a lot of regulations and they take risk very, very seriously. And so part of what the plans are doing now is they're vetting who they're going to contract with. We had to sign a very, very extensive, what's called business associate agreement. There's a lot of compliance requirements with that, and HIPAA, the Health Information Patient Portability Act, or yeah, I think that's what it's called, is a really big part of that. So, and Paul can talk about his work around high trust certification, and HIPAA is very extensive. There's a lot of cybersecurity pieces related to it. So there's the contract relationship with one piece of it. And then there's actually the relationship of understanding the plans world and restrictions and how they need to operate, and them understanding yours and making sure that as you build that communication and data pathway between your organizations, how you're submitting data, what information they need in the treatment authorization request. These have been different worlds. And I'll say that's what took us that 5 or 6 months, is we communicate in ways that are different than they communicated. We had to find that common language and ways that our information would be able to move through their system without being kicked back for various things. The way that we work doesn't fit in their, they're working with encounter data, a patient encounter in a health clinic. We're delivering 7 meals, or 14 meals once a week. So it's not a daily thing. There's like all these ways that the communication does not work. And so there's a big gap there. And I think in my experience with partnership, everybody's got really great intent, but it takes a while to get on the same page about how things are going to work.
Yeah. And for me, I can tell you right now, I have 4 contracts with 4 different managed care organizations, all Medi-Cal managed care organizations, 1 regional and 3 county-based. And all 4 of those contracts, the relationship's entirely different. And what I think is really important that we've learned, 1 county has a case manager that sends us the referrals, and we're probably getting the highest quality referrals from that county. Another county has a chief medical officer that actually contacted us to contract. So we're getting the highest volume from that county, maybe a little bit different quality, but there's definitely a push. And then two of the other ones are, this service is not their highest priority. So we have to kind of push and go back and forth with them to explain the process and to work that out. So I think that we'll all we'll have different experiences based on how committed the payer is to this type of service, which I think that's the case with any sort of community-based health and wellness referrals.
Yep. And I'll just chime on that we also have 3 area agency on aging contracts, and every contract, and we have some other fee-for-service contracts as well. Every single one has very specific eligibility, like who could get that, who can be served by that contract, compliance requirements, tracking and data requirements, and they're all different. And we have a proprietary Salesforce database system that's very robust, and we've had to invest in building out new capacity to be able to track more in a more detailed way the way one of our clients moves between funding sources and when they do, so that we can pull data for each funder specific to when that funder was funding that client. Claims billing, we have had to implement Easy Claim, Tableau. We're going to have to implement collective medical. So there's a whole number of IT systems. And then you've got to make sure that you have staff who can deal with the translation between those systems. It's Paul, let you add it. It's just complicated.
Yeah, and that's related to the question in the chat. We also invested in a new client service database that's, I think that was several $100,000 that we've been working on for a year and a half. But we have 7,000 clients too that we really have to manage it like it's an electronic medical record. Yeah. And so that we're finding that some of the data we thought the health plans were going to want, they actually want some other things. Like they want client experience or member experience is really important to health plans. So we're starting to look at how do we capture that information when someone has been on the service for a little while, or we discharge, because they love that type of information. We found out that some of our firewall, our server needed to be upgraded to meet the demands, and so that the external, never knew these words ever in my life before, but the penetration and vulnerability testing for an outside consultant to try and hack our system, we had to make some changes. And once we get this certification, then it's good for 2 years, but we have to keep it up every 2 years in order to show the health plans that we have this level of security. And then, some internal, I think that just how we manage data was less of a challenge for us because we've done HIV work for 37 years and there's a lot of really obviously highly confidential mindset towards HIPAA with that from the beginning. But in the food production side, there's an increased scrutiny on what we call route sheets. We have a list of 500 people that are getting a meal on this route. You have to be careful that route sheet doesn't have any health identifiable information. So there are other aspects of the operation that we have heightened level of attention to because of some of these contracts with health plans.
Yeah. We have a IT support firm that works with us, and we also have a HIPAA support firm that works with us, and we meet with them quarterly. We're managing a continual improvement process with HIPAA, and they do quarterly vulnerability scans. And basically the HIPAA consulting firms, if we were audited for HIPAA, they attest to all the policies and procedures and work that we put in place to support HIPAA compliance. Do we track our sourcing for your meals? In terms of, so Ceres is, we're different in this, but Ceres is 100% organic. And we buy about 70% of our food locally, depending on how you define that, not within 100 miles, but within, northern central California. And Paul is doing a lot of work around improving sustainability of their food supply at Project Open Hand. None of the plans care about that, just so you know. They care about price and the ease of working with us.
Yeah, and we've been pushing that, with there's one national plan that Cathryn and I both lost a contract to, that clearly did not care about that at all. And we tried to make the point, well, not only in Cathryn's case is it 100% organic, we are trying to be more sustainable, with over 1 million meals a year. It's a little, we have some added challenges, from a price perspective. But we did try and we tried to remind them of the case that it's all produced by people here in Northern California.
Creates jobs,
creates
supports
jobs.
California agriculture.
We have
blah, blah, blah.
9,000 volunteers. We're really connected to the community, and that just kind of went out on deaf ears.
Yeah, we won't name them.
Because they're gonna turn it around. We're pretty sure they're going to.
We're gonna make them turn it around. Yeah.
Robin has
Do they care about so nutrient density? I mean, so what matters in this space right now is that we meet so this is the challenge. There is a difference between meeting nutrition standards and meeting nutritional quality. And the field right now, what matters for a medically tailored meal is that your meal meets the nutritional guidelines for that diagnosis. We all, this group, all carrots are not the same, and there's all kinds of implications for soil health and our future ability to grow food by the way we source food. And Paul and I both know that and support that. That is not relevant here. That doesn't mean that we don't prioritize it, and we don't bring that conversation forward. So I'll just say in a really good note, the U.S. Department of Agriculture is now using the term sustainable nutrition, which is aimed at talking about the quality of nutrition, starting with soil health and nutrient density. There's actually a big study that they're working on now that's going to track soil health, nutrient density, human health, and look at those things. So there's some really important work happening, but it's going to take a while because those studies take time. But there's some real champions at USDA around that conversation.
That's great to hear.
Okay, so we probably should wrap our part. But thank you, everyone. And I didn't mean to be overwhelming, but I think it's really important to kind of lay out the real picture of what's happening in the broader field and what the opportunity right now in California is and isn't, and who can really leverage it. And I'll just say some of the health plans are allowing their contractors to subcontract, and some are not. Partnership is not right now. They are requiring everybody who's working with them to have a direct contract with them, which means you've got to do that whole lift. I am very, very much trying to get them to switch on that, because there are many smaller CBOs that are never going to contract with partnership. And it's a real misstart. It really makes some things more challenging than they need to be. So.
One more question here for you, Cathryn, on the studies. Robin is wondering if they're studying aquaponics and hydroponically grown foods, nutrient density versus the soil.
I'm not aware. I know there's a big controversy among regenerative ag people with whether hydroponic people can be certified organic, and I'm not deeply enough involved in that to have a point on it. Sorry. Can I ask, do you want us to stay on, Stephanie, or?
Well, if you have the time for maybe another 20 or 30 minutes, I think it might be good. Okay. I actually, after hearing all of the, like you say, this is, a very heavy lift for CBOs. I have a couple things running through my head. And one is, is it even realistic to think that you could design this on like a hyper local model where you just have one CBO working with one provider and not with multiple? I don't know.
We're in a weird situation because like Alameda Alliance and Alameda is contracting with their plan. It's one county. There are managed care plans that are only in one county. And they are very happy to work with the local provider, or Central California Alliance for Health that we mentioned before. They're in 2 counties. So partnership is odd. Now, partnership is contracting with many people across their geography, but there just aren't any providers in a lot of their geography. If you look at Trinity, like, you know, they have such a rural geography that most of those counties don't have the philanthropic base to support this kind of thing. So that's the challenge.
And, you know, one model we're looking at here in San Francisco County is we're working with a local foundation that's very, very interested in all aspects of nutrition and health. And we're looking at some ways that we might have one contract to like Project Open Hand, but for a service we don't provide, like a veggie voucher, we would subcontract with another smaller CBO, or if there was a specific type of grocery product or grower that we can't provide, we would do some of the subcontracting, but we haven't gotten that far yet. And I think because the community supports piece is just so new. I do know another managed care county who's opted to do 3 or 4 contracts just to see how it goes, just kind of like doing their own little pilot, but it's more labor intensive for the contracting division within the health plan. And it's probably not going to go that way forever.
Okay, thanks for mentioning that, because I was trying to think, like, is there an entry level spot for some of these organizations? I mean, with like the veggie bag, or, you know, the produce prescription, that's a lot easier than making a meal.
Yeah, and partnership isn't contracting with anyone for Produce RX. They're only contracting for medically tailored meals or medically tailored groceries of either 7 or 14 meals a week. But Produce RX is mostly being funded by USDA now, you guys know, through GusHIP. Yeah.
But it does, you know, it made us think a little bit more about the continuum that we showed you in the beginning of the slides. You know, we've been using the concept here at Project Open Hand. I've been sharing with Cathryn over the last year or so is, I know that the patient-centered medical home really resonates in the health clinic and in the hospital system. Similarly, we're talking about a client-centered nutrition home. So is there a point where some localized entity could really help connect people with all the what's most appropriate? Not everyone that comes to us needs a medically tailored meal, and it's more expensive than a bag of groceries. So we want to make sure that we're the most judicious with what we're providing, and with healthcare dollars too. And we've all done referrals throughout multiple agencies for years and years, but I don't think in the nutrition world it's as thoughtful and strategic as it could be. Yeah. We're looking at when we have someone receiving a medically tailored meal for, let's say, 6 months, and they're discharged from our meal service, have we made sure that they're enrolled in EBT? If there's a child in the home, is the child and the mother enrolled in WIC? Do they have all access to those other types of nutrition supports that you know, we know we're underutilizing EBT in this state. So we're trying to figure out what role can we play to be a little more thoughtful about how that happens.
This is this field is so young, and there's so much work still to do to understand what we call the duration and intensity of the intervention that's needed to make the difference for the patient in a whole host of ways. And we're also really in this conversation around what do different patient populations need in terms of the number of foods, the amount of food support, the mix of food support, for how long, with what level of nutrition education, RDN intervention, in order to really make sure that we're doing the best by them, but it's also cost effective and something that a healthcare provider will pay for. So it's really, really shifting in a good way, I think, the way that we think about our work.
Mm-hmm. Oh, I'm also thinking, and Lauren, you can chime in here if you want, you know, we attended that MTM talk at EcoFarm, and there were 2 presenters.
Who presented on MTM at EcoFarm?
Well, you know, it was called Food is Medicine. It was not called MTM. But it was Recipe for Health. Was it Shen, I think? And
Stephen Shen, he's from Alameda. Yep.
Alameda, and then Communicare.
Yep.
Edie Kuiper.
Yep.
I'm saying her name right.
Stephen's doing some great stuff in Alameda.
And what became really clear was that, you know, the meal part is just one element, like you were just saying, Cathryn. There then needs to be this whole other host of services, from, you know, mental wellness to exercise and, you know, the whole package. It's not just those nutrition follow-ups that need to happen. And so one thing I was wondering is, you know, you said that Cali was helping to support, you know, 14 different services or something like that. Housing is one, but would some of that fall under that too?
None of it's exercise. No, the meal, the food, the nutrition support benefit is medically tailored meals, medically tailored groceries, healthy food boxes, which the plans just don't understand what to do with. Like, the plans want to do the things that have the most evidence base behind them. They're not going to risk things that don't have the evidence base behind them. And nutrition consults. So one-on-one RDN kind of meetings to support people. That's what's covered, and none of the rest of it. Yeah. We have a long way to go.
Yeah. Okay.
Also, Troy and Sasha, the farmers for Dig Deep Farms, were also present. And I thought that was a really nice, like, full circle. They had the doctor, the sort of administrator, and then the farmer who grew the food for their program. So that was cool.
All right. Anyone else have questions for Cathryn or Paul right off the bat? If not, I want to move over to Norma, who has done local work here in Solano with some pilots. And so we've kind of like seen the big broad picture and what's happening up at the top and the plans and where the funding is coming from. And so now I thought we could kind of move it a little more local and learn about what's been happening and how some of this might be able to come into Solano County. So Norma, go ahead.
Yes, hi everyone. Norma Lisenko with Innovative Health Solutions. So just to give you a quick background of what happened in early 2021, we, as you know, here in Solano County, we provide direct services to our older adult population through funding from the Area Agency on Aging, which has funding from CDA and CDSS. So in 2021, late 2020, early 2021, AAA locally, Napa and Solano AAA had some extra funding that they needed to spend. And so they looked at our service providers and put out a notice saying, is there anything innovative that anybody could do with this extra funding? It will be a 9-month funding because it had to be spent by September. And so Riva Meek, so you know, our former CEO, has got a very close partnership with Cathryn. And so at the time, she said, Cathryn is doing, Ceres is doing a great job with medically tailored meals. And this is, and so this funding needed to target older adults. And so Riva Meeks, connected me with, contacted Cathryn and said, is this something that you would be, interested in helping us to do, providing medically tailored meals? However, for us, it wasn't just medically tailored meals because, as you know, we are a service providers for nutrition and physical activity education. So the way we wanted to do it for older, again, this is all for older adults. So the way we wanted to do it is, and we created what we call Health RX. Health RX was a program that provided case management around nutrition, education, physical activity, fall prevention, food RX through our partner with the county, and the extra would be medically tailored meals. So we conducted the pilot program starting in January of 2021. We were able to have 90 participants to join this medically tailored Health RX program. I don't want to call it MTA because it was really Health RX program. And 90 participants would every week have a physical activity, nutrition assessment, counseling, education, medically tailored meals, and also a bag of produce through the Food RX program from Solano County. We partner with we wanted to originally partner with La Clinica because they will be providing the referrals of patients. Unfortunately, that didn't come into fruition. So we had to quickly pivot, and we partner with the Solano County Clinic Family Health and Services. And so we were able to do our partnership with that local clinic, county clinic. So by the end of 2021, we were able to complete that project, and it was very successful. Obviously, funding was a one-time funding, so we ran out and moved on. Well, now with ARPA funding, I don't know if anybody knows the ARPA funding. I think we're here. Everybody, let me know if you don't, and I'll explain it. But through ARPA funding available through the area agency on aging, again, I said, hey, medically tailored meal program was very successful. I would consider doing a little pilot again with ARPA funding. And so, however, this time around, we're not doing the whole HealthRx project because it was very intense, very not time consuming, but we require a lot of staff to do that. So now what we're doing is we're partnering with Aliados Health, which is a coalition of local health clinics. And so through a partnership with them, we're hoping again to develop this new pilot project for medically tailored meals with La Clínica. So La Clínica in Vallejo has a diabetes clinic. And so through that partnership, we would have the referrals. To make it more local, we have contracted with Provisions. As you all know, Provisions is a local restaurant here in Vallejo to provide those meals. And we have a RD on staff, Denise Kernick, who's going to be providing the RDN component for the medically tailored meals. Now, the funding is fully coming from AAA, area agents, Napa Solano AAA. And so that's how we're going to, so we have proposed that now we're going to be delivering, we're going to be creating a cohort of 50 participants. We will be providing 10 meals per week and 1 produce box per week to 10 participants for 12 weeks. That's the original proposal for the funding. With this whole CalAIM program or project with partnership, we decided that, again, it's true what Cathryn says, it's a long process. It doesn't really pay what you're paying for. It doesn't pay for coordination. It doesn't pay for anything, but just the $9.50 per meal. And yeah, anyways, and we do get like something for a produce box and also for a nutrition assessment. So it really doesn't even cover your costs. So we decided to do a contract to meet a community contract with partnership, because we already have the funding. So like Cathryn's saying, whatever we get from partnership, it will be just extra to cover maybe this program in the future, but it wouldn't sustain this program as it is. So the fact that we have that funding is why we decided to go ahead and go into contract with partnership. And with that partnership, with that contract, there's other technical support assistance that we can also access to. There's like a PATH grant, which, I don't know. Anyways, so there's a couple of other things that we're looking at and working with a couple of people who are going through this process or have gone through this process. So anyways, back to MTM. That's pretty much what we have. I don't know if you have any questions. I don't want to take too much of the time. So if you have questions, I can add more to this.
I just want to caution you to call it MTM. Did the RDN create the menu plan, and then is she overseeing the meal production
So
from the restaurant?
So the process is the restaurant will provide the meal plan, not the meal plan, but the recipes, the menu, I guess, if I were to call it. That's gonna go to our RD. She's gonna go through this process of analyzing the ingredient, all of the that portion of it. AAA, the Solano, Napa and Solano Area Agency on Aging also has an RD that we have to, as you know, Cathryn, we have to get authorization through her as well. So those menus will have to go through those two RDs to get approved before we can, and then it goes back to the rest, the provisions and staff, and then we go from there.
Yeah. There's a whole quality assurance process that we do of oversight of the actual meal production, not just the menu plan. So there's a lot of things that can break down between the menu plan and the actual creation of those meals, packaging of those meals, getting the right meals in the right bags to the right people. So I would just think about that piece. What's the RDN's role in terms of quality assurance and oversight when you've got a restaurant doing this that isn't used to doing this kind of thing? So I would just be concerned about that.
Thank you.
Yeah.
Okay. Any other questions before we move on? And Lauren, so Lauren has been running a youth pilot with the idea that how could some of these youth move into cooking for a medically tailored meal scenario. Go ahead, Lauren.
Yes. Hi, everybody. Norma, thank you so much for your description of the work you've been doing in Solano County. It's really great to know that it's happening nationally, it's happening locally, it's happening regionally. And so like Stephanie said, I have been piloting a youth culinary internship. So I'm just gonna share my screen with y'all. I made some cute photos of students cooking in the kitchen. Here we go. Share. How does that look? Oh, whoops, that's not it. Excuse me. Thanks for sticking with me. Allison, I see you smiling.
You had it. You just want to go to the present mode.
The present mode. Thank you. Okay. Slideshow. How's that? Okay, thank you. So my name's Lauren Gucik. I'm a program manager here at Sustainable Solano for the Solano Gardens program, and I'm on the local food guild. And I've been a food industry worker pretty much my entire life since I was a teenager. Worked in kitchens and coffee shops and in tech offices. And most recently, I have been a youth educator, creating farm to fork culinary experiences at a public high school in Oakland, and now through internships here in Solano County. And I'm an advocate for equity, and I use trauma-informed approaches in my facilitation. And so our program, Solano Gardens, is funded through the Department of Public Health. And our goals are to increase local food production while building community wealth, sharing resources, and improving our mental and physical health of our communities here in Solano County. And so one of the ways that we do this is through a youth culinary internship. And so you can see here different groups of students coming together. And our internship goals are to provide workforce development opportunities for high school age students. And we were really looking to see what it takes to pilot cooking in large batches with youth. So Cathryn sort of alluded to this organization that she has created around providing medically tailored meals. And Cathryn, I don't know if you want to jump in and just give like a really quick overview of what you do at Ceres.
Yeah, I mean, I didn't talk about Ceres at all, but we started 16 years ago, basically with the mission to teach teens how to cook by having them make meals for people in the community who are going through illness. So we have a robust youth development program that includes growing, cooking, and eating healthy food, work readiness, and leadership development. And we engage, pre-pandemic was about 450 kids from 40 different schools, and about 30,000 youth hours a year.
Wow. Thank you so much, Cathryn. And actually, so Sustainable Solano has done some training programs with Ceres. And as a result of this, we have been running these internships. And so the students get to practice culinary skills, prepare different recipes. We explore concepts of nutrition. Some students actually visit local farms. And this year's pilot was really looking at, can we create enough food that students could take that food home and share with their families? So we started this pilot in October. We were at the Ulatis Community Center in Vacaville. Students received a stipend of $450, and they also have the opportunity to get their food handler's card. And so here's just a few photos. We really focus on personal empowerment and leadership development. And by the end, we actually had some students able to teach the other students who maybe missed a class. This is actually Cameron here showing how to emulsify a dressing. And down here in the corner, students measuring. And we actually had a partnership with Meals on Wheels. I see you, Lori, here. We really wanted to try and pilot this idea of, can we cook enough food to share with the community? And we wanted our students to participate in this act of service that is really so alive in the Ceres model. And so we prepared, it's a very small amount, but we wanted to start small so we could have that, you know, quality assurance moment and real food safety. So we made 15 salads. We did sweet potato granola to take home, and all the food was California grown. And we also were able to source many ingredients from Solano. And you can see here, the students actually made cards, and you know, we're looking to hopefully be able to share a meal together in the future. But the lunchtime meal was happening during the kids' school hour. But yeah, so our recipe approach, we use the concept of food as medicine. So our recipes were plant-based. We really designed them to be culturally affirming for the students who were in the class. We tried to make them as nutrient dense as possible, and we did that by sourcing from farms who are using regenerative agriculture practices. And our menus are seasonal, and they also celebrate our local farmers. So here's Chef Steph kind of buy some ingredients, and one of our students chopping nuts from Beloved Farm for that sweet potato granola. And really our findings through this pilot program was it's very well received by students and families. We basically had 100% attendance rate for all of our classes. And if a student missed, which was like 1 or 2 times in 12 weeks for something pre-planned, they always made up the work. And so that shows us how big the need is. Every time we run one of these pilots, we have a wait list of students attempting to get in. You can see us here at the beginning. We actually tried to cook large batches and package the food, just kind of practicing that with students. But we found that it takes a lot of time, space, and we needed a lot larger support systems for that to happen. So we were renting a kitchen for 5 hours a day, sometimes with 1 adult to 10 students. So we had a very good time. Students ate well, but we couldn't really produce large amounts of food in that time with that design. So our major adjustment was we switched to sending home students with a bag of ingredients. And so they ate the meal together, and then they were able to cook it at home again for their family. And we actually got a lot of really great feedback that students like that model even more than just taking home to reheat the food. It gave them more opportunities to practice their culinary skills. And then always, I'm going to wrap up my presentation by really showing a lot of love for our farmers and local producers. This is just a list of some of the farms that we procured from: Lockwood Acres, Beloved Farms, We used olive oil and balsamic from Sepe Groves, and we were able to support Spork Food Hub, which is a new kind of food hub on the scene, not new to Solano farmers for sure. But yeah, so that is our program in a nutshell. I can stop sharing. It's been a lot of fun working with the students. So yeah, any questions? Comments?
If you want to come over and see what it's like when they're producing really big batches, feel free.
Thank you so much. Yes, it's on the work plan. I know my colleagues got to do that before my time. And a friend of mine, this is a sidebar, a friend of mine is a garden volunteer in Sebastopol with you. So I get to hear a lot of great stories about that integration of garden and cooking.
Yeah. Thank you, Lauren. I know. Any other questions from or comments from the group? What's coming up for me is that there's a lot of bits and pieces, and it's like, how do we start bringing it all together? There's our work kind of on the ground with youth. There's this much larger work that Cathryn is doing. And so.
And I have a question. So Cathryn and Paul, part of this coalition, the Food is Medicine Coalition, is that, and again, I'm just thinking about it, and I was just talking to Stephanie about it. Is there, I know there's members to it. Is that something that is open for other organizations to join?
Yeah, it's, but you need to be accredited. So you need to be actually meeting the standards that we have nationally around offering at least 3 different diets, RDN oversight, a quality assurance program, all of those things. So yeah.
We had 2 new members come in 2 years ago, I think.
2 or 3.
One from Santa Cruz and one from Fresno.
Yeah.
And is that, so do we, if we're interested, do we just go on the website and there's like a form?
No, you should email me.
Oh, Cathryn,
Yeah.
okay.
Yeah, I mean, we show, I mean, yeah, you need to have a pretty robust program. Because we're working at a certain level, and we want members that can participate at that level. So, but yeah, and I'm happy to share the FEMIC accreditation standards. That
would be great. I mean, I think that if we're going to be doing this and, being neighbor counties, I think we should all, get to those standards. So I will email you and find out.
Great.
Yeah, thank you.
Okay. All right. It's almost 5:30. I know that Cathryn and Paul had kind of a time restraint. So if there's no other questions for them specifically, I think we will say farewell and thank you very much.
Thank you guys. Good luck and stay in touch.
Yeah. Nice to meet you all. See ya. Bye.
Okay.
Thank you. Bye. One thing that is coming up for me, Stephanie, and I know I'm probably going to open it up, but is that connection to the clinics. It's that referral service. So I know, Norma, you've had success in that, but that's something that is really like, I'm like, oh, okay, the clinics, we got to invite the clinics in to this conversation.
So I would, we're currently in partnership with Aliados Health, who again is this coalition of clinics. They help or provide technical assistance support to all the local community health clinics. So all the health, La Clinica, CMA or CMT, I can't remember the year. But so yes, that is definitely. I don't know if they're ready for this yet, though. So that's the one thing. It continues to be a struggle. Again, they're not into providing food to their patients. So yeah, I don't know how they will take it.
Even though, like, if the funding is coming from a larger level, and they are connecting to those clients.
But so if we're talking about Colleen, is that what you're talking about?
Well, I was thinking more in terms of them. Well, is it Medi-Cal and then it goes down to the Cal AIM. I'm still struggling with some of the medical.
So
bits
like
of
Cathryn
this.
is saying, if you're telling the clinic, oh, you can get funding through partnership, right, CalAIM, they're only paying $9.50 per meal. They're not paying anything else. So I don't think a clinic would be in the business of providing those meals to it's not, yeah,
No,
it's not
Norma, I
gonna.
think this is Denise Koenig, and I think what Solano County is slow to do is because most providers, a lot are the providers that serve Medi-Cal clients and are part of partnership, they're not making the referral to partnership for the person to get a medically tailored meal. It's very low numbers of providers that are even making that referral, because they can get a medically tailored meal right now. It's already set up. Ceres is one of the providers to get it, but at least what partnership told us is they don't get that many. So our providers either don't know about it or don't understand the return on investment. I feel like that's definitely an area that we can work on to improve. And I don't know what partnership has done. That was something I had written down, is to find out from partnership what they've done to market the program to providers to make that referral. Because that's the first step, is they have to really realize the benefit and make the referral. Because if the amount of referrals go up, the need goes up, and then we go from there.
Yeah, Tracy, you had your hand up. Go ahead. Can you, oh yeah, okay. Oh, I think you're muted.
I am muted. First, I want to say thank you, and I want to make sure, I'm not sure if I'm in your meeting now, and I'm not supposed to be. I just got the thing in the mail about the guest speaker, so
you can be here.
okay, thank
Sure.
you.
Well,
But it's just fantastic. It's incredible, and I think I have spoken to some of you via email. I work at Toro University, and I am just beginning to start working in the clinic over at Olay in Napa, not here in Solano, but we have providers here in Solano as well. I have been out of clinic for a while, so I'm learning a lot of this as well. But I think that I think if there's a way to partnership with the clinics, I would love to be the voice for that. There is a severe problem. The fact that you don't have any physicians talking about this disaster of childhood obesity and chronic disease. I shouldn't say you don't have any, you have plenty, but even in our own healthcare field, it's like we're beating against the wall, trying to get the medical industry to move in this direction instead of prescribing the drugs and the bariatric surgery, which were the most recent American Academy of Pediatric guidelines. So I'll try not to get on my soapbox, but if there's any way that I can help bring those things to fruition, please let me know. I think like everywhere, groups, it takes a long time to get things going. At Toro, we do have a pretty good foundation of diabetes research, and we have the MOBEC, which is a mobile unit that goes around. We're actually trying to get a teaching kitchen in there right now. That's been an issue because of rules and regulations, but we are getting closer to that. We do culinary medicine in our undergrad medical curriculum now. And so we have a lot of students, and we also have a curriculum of structural competency, which I happen to teach them both. So we have a lot of students that are out there that are always looking for places to volunteer and are passionate about this. So if there's a way, and we're always writing for grants as well, we don't always get them, but this is, I think, where exactly we could potentially be a partner, and I think we would like to. I think Toro has a big mission to social justice, yet I don't think we have a very big footprint in Vallejo as much as we should in terms of partnering and helping things grow. And then finally, I am personally meeting with my boss very soon to argue that I don't want to go to the clinic and see 30 people a day and write prescriptions, and I'm hoping that they will let me be more of a culinary medicine specialist there. So there may be a doorway into continue with these partnerships. So again, if anyone wants to contact me, if there's any way I can kind of help you all with your things, I would love to. And I do think, I don't think any people, I know very few people are even aware that Medicare and Medicaid and the CalAIM are actually providing reimbursements. So that is something that I'm hoping to work on with the clinic, NLA, as well as our providers in Solano, is just making them aware of that. And that is the first step to making the referrals. You know, it's a huge push to be patient-centered medical home. But what tends to happen is it becomes, yeah, that looks good on paper and we get a check off, but we don't actually really maximize these kinds of things.
And Tracy, I'm sorry, I don't think so you're with Toro, I get that. Are you a doctor? Are you a nurse?
I'm a family physician.
Oh,
So
okay.
in general, Toro, part of our job is, the majority of my job is on campus, but we also work at the community health centers. So we have providers at the Solano community health centers, and now we just started going over to clinical Olay in Napa as well.
Are you involved with the HRSA grant that they're going to be, Toro is going to be training our community health workers or creating a type of certification for our community health workers?
I am not directly involved in that one. I am aware of it, but
Because I think that would be a great place where we could, oh, where did she go? Oh, there you are, where we could educate our community health workers who are the liaisons for the, you know, at all of the clinics to, you know, talk about this medically tailored meal. So I'm hoping that Toro will add that as one of those modules for the training.
yeah, fantastic. Yeah, if you shoot me an email, I'll try to ask around and see as well, and just keep those ideas going.
Yes, thank you.
Yeah, and Tracy,
oh.
I would love, and Tracy, I'd love to get your number if you want to put it in the chat and just kind of talk to you about some of the programs that we will have up and coming, dealing with local food education and kind of getting some community ambassadors for that. So.
Yeah, Tracy, I think I've been in touch with you on and off over the years, so I'll connect you with Noah, and we'll get on the same page about that too. Robin, you have your hand raised, I see.
Oh, thank you, Stephanie. I just had a question for Dr. Stevenson, just to follow up on what you were saying. I think that we've had a challenge, I would say, in public health for quite a while, just trying to find the most powerful ways to try to break through, not only with our own clinics, but other partner clinics on some of the primary prevention work. So everything from treating tobacco use and secondhand smoke exposure as a vital sign, through type 2 diabetes screening, to asthma education, I mean, kind of like you name it. And we understand, like, it's just a turn and burn kind of, you know, situation in the clinics. If you only have a few minutes to see patients, it tends to be, you know, focus on like what is the most severe issue that you're seeing. You know, is it what it, you know, whatever the situation is, it's kind of put out the fire, and it's a challenge to get, you know, primary prevention for any of these issues on the docket or in the EHR, or, you know. So I'm just curious, because this is, to me, this is super important. And it's also, some of the other things I mentioned are very important also. So, and I was thinking, we've tried a bunch of different things. And even with Mobec, you know, working with Dr. Jay Shubrook as a physician champion in our clinics, talking to other providers, I was so excited. I thought, okay, now that's going to work. So I just come to you and just ask, do you have insight on what else we can try to kind of have a breakthrough on, is it physician to physician? Is it, what would really help? What do you see in terms of like a breakthrough that we could work with not only, the community clinics, but well, I mean, it's a both and it's the community clinics, it's any of the FQHCs and some of the, the bigger hospitals as well. So that's the $1 million question, but I just have to get your insight. I think you're on mute.
Oh, sorry. You think I know Zoom by now. It's a huge question. I think it's a bandwidth issue, and that there's so many things that awesome people are doing all over, but everyone's in kind of their little bit of silo, and we almost need a navigator to help bring all the different groups together. Then they can synergize and maximize their resources. But just like Sustainable Solano, kind of advertising is how I heard about that. And then I'm, here. So it's slowly moving, and just trying to bring in more partnerships is, I don't have a great answer, but I think that would be the way that things could work. There's some concepts from the Institute of Healthcare Improvement about these things called equity labs, where they're templates to bring together all sorts of stakeholders in the community. And then you kind of incubate over 90 days of what each of these different things could, you build your goals and objectives, and then how can all these different people do it. It's a concept I think would be great to try out. It's no one has enough time. I haven't been able to get anyone even at Toro to do an equity lab with me yet, but if anyone's out there thinking about it or interested, it seems to me you have to bring together all of the stakeholders in a community. And that's the difficult part, because we're all in our own silo, and half the time not even aware of what the other people are doing. But we could very much maximize our resources instead of compete with each other for the same limited amount of resources.
Well, thank you for your insight. Appreciate it.
Thank you. So all of this is part of a vision that we've had in Solano County. Oh, Elena has a question. Can we do equity lab for MTM development in the county?
I'm sure you could, if you had, we just have to have people who can come together and have the time and commit to it. But, and I don't want to take over your meeting, but I'm happy to talk more about the equity lab or anything at any time in the future. And I imagine you all have heard, but the White House in September had the first ever conference. I mean, we all know the government works at snail pace, but I do think this is the time, if there's a time, to keep your eye open for the grants and be ready to jump on them. And there was definitely a big movement of medical tailored meals from the American Heart Association discussed at that conference. So it's on the radar high up in Congress and things. So it's the perfect time to hopefully build that momentum and potentially have your systems in place that you can be some of the people to receive the grant money when it starts flowing out.
The question is, how do we bring it all together and start moving toward that vision? I know that, Norma, we're going to be working with you to just figure out who needs to be at the table. I don't know, that was so much information. It's like, oh, where do we start?
I think that at this point, what we're doing is, we're conducting this pilot. It's, even though we did it before, there's still some things to be worked on, kind of logistics. And one of them was to do it locally. Obviously Ceres it continues to be a vendor for MTM, but they're in Sonoma. So we're hoping that Provisions, and you all know Provisions, can build that capacity. And Nicole there is very willing to provide these meals for us. The meals she's providing, they're coming at $10 a meal. And again, if we didn't have this AAA funding, we wouldn't be able to do it because partnership is reimbursing us at, contracted to reimburse us at $9.50 a meal. So, yeah, we'll figure, again, we're already in contract with partnership. We have this funding to do this pilot. So I guess I'll give you a report at the end of the year to see how it's all going. At this point, that's all I have.
Mhm.
But I think the program that you're building right now, it's so important. And I think Lori's left, but working with Lori from Meals on Wheels.
Lori, yeah, I think she did leave.
To see how, because they're building like a huge new kitchen, and how is that, so I think we just keep doing what we're doing. You continue to work with high school students, continue to build that program. Once Meals on Wheels has the nice kitchen that they are building, and maybe next year we can, you can partner with them and maybe we can buy the meals from you. I don't know where this is all going, but I think we're doing exactly what we need to be doing right now, kind of figuring it all out. And I will tell you one thing, which they, when I submitted the application to partnership, everyone said the same thing. Oh, it's going to be very tedious. It's going to take a long time. It's hard to get in. It took a week, and what I gather is that because Solano County, no one's really applying or trying to be a contract with them. They are willing to work with us to to CBOs to figure it out. But so my application got accepted within a few weeks, to be honest with you. And I was like, whoa, wait, I'm not ready for this. So now I'm working with a firm to help me build capacity, apply for a grant. There's some technical assistance that they're providing. So we'll see how it goes. So like I said, at the end of this year, I will come back to this group and give you a full report of how it all went.
Elena, go ahead.
I think one other steps we could probably take at this point is to put a call out for others interested stakeholders. Because, it's very early and some of us are already walking the path, but there might be other, prepared food facilities that are interested. I know someone is on the call now that might be interested, could be other youth groups. Like, I feel like we need to bring all of us together. And that's the work we at Sustainable Solano are committed to do, but we need to hear who else is interested at this point and how could we spread the word so we don't miss at this early stage entities in organizations, people who could help us move it forward with that vision to create an enterprise here where ideally we could have all these elements, so it's not just adults, professionals providing food, right, with all these partnerships and things, but also have youth component to it. Because that Ceres model is so wonderful. So we are still, I feel like, at the vision level, even though some of us are for a little bit, So is anyone on the call would like to unmute and maybe speak up so we could capture the other interest?
Elena, I think you might have been talking about me. So I'm.
Yeah, I didn't want to put you on the spot, but yes, Sherry. Hi.
Hi. This has been so wonderful. So thank you. And for those of you who don't know me, I'm one of the co-founders and president of Thistle. We deliver healthy, plant-forward meals, and our headquarters is in Vacaville. And we're really excited to learn more and to potentially get involved and get into the space and help the community however we can. So yeah, we'd certainly be one of those parties that are super interested.
That's great. Lauren, go ahead.
Well, I wanted to kind of add something to what you said, Elena, which was really because our like strong alliance with the local farmers, I'm very excited to see how that will play out with what we do in Solano County. And something that at the eco farm, that this word got thrown around a lot and people were excited, but this idea of like a guaranteed market for our local farmers, if we had something where we knew people needed, they were going to buy this much food for this many meals, then we could really start triangulating between new and beginning farmers in Solano, kind of these local food enterprises, and then the people who need the medically tailored meals. So yeah, nice to see you and nice to meet you. And I think this is an exciting conversation.
And I think it's great that it happens in the framework of the alliance where farmers are members. And that's exactly what we're trying to ensure, that, you know, when it does take off, so it's not, again, someone in Midwest supplying just because it's cheaper, right? How could we ensure that it's our people employed, you know, our people benefiting, our businesses are paid, our farmers are supplying? That's the vision. And we need all hands on deck now to make it happen.
Yeah, it was a bit disheartening to hear Cathryn say that the the funders don't care if it's organic or grown on a regenerative farm, but you know, the part of the point of this is to be supporting those farms that are doing it, I don't know, I like to say correctly, that is helping the environment, and which, to your point, Winona, ties back into the climate and, you know, is healthier food all around. So.
But I think that the important thing is that we partner, like again, Nicole from Provisions, right? We know already that that's what she's going to do. That's what she does. And Sherry is your name, Sherry?
That's right.
When I was looking for a vendor in Solano County, we couldn't find a vendor. So it's good to have your information for any future references. But yeah, just to partner with vendors who care about their ingredients and are buying local and are buying organic, and again, can deliver a product that is, you know, within somewhere the price. We were very blessed that Provision says, you know, it'll be $10 per meal. Otherwise, I don't know if I could have been able to, you know, afford more than that. So
yeah, and $9.50 that was the. Oh, sorry.
Go ahead.
I was just gonna, you said $9.50 was the reimbursement rate, correct?
$9.50, yes. And that is it. There's no coordination,
Yeah.
there's no fiscal,
Yeah.
there's no admin, just a meal, $9.50.
And
No
they do pay
transportation.
like around $40 to call them for the first time to find
The
out.
nutrition assessment, yeah. We get
Yeah,
two
to do
nutrition assessment
yeah.
of $41
Like
per piece.
Yeah.
And
That's
then
it.
boxes at $66 per box meal
Grocery.
product, groceries. Mhm.
You know, I was gonna say, even though they're saying providers or health plans don't care about the quality of the food, what they do care about, when I heard from Partnership, is they do have providers that they have tried this medically tailored meals. And when they call participants to say, did you like the meal? They're like, no, I didn't like it. And they didn't eat it. And so they've dropped some providers because the quality wasn't good. So, and she did say that health plans care about the member experience. So that's, I think, where great tasting food that's healthy, you know, will sell itself and people will be satisfied and love it. And that's how we do it, instead of saying it's this and that. They're okay, we're going to go with you because it's local and organic and all that.
Well, and just building on that concept too, I mean, we can decide as a group that we want to source from local farmers. We could try to promote that, and whether or not the institution of, you know, the hospital or the HMO insurer cares or not, we care that it's, you know, that we're supporting local farmers too. So it just seems like there might be a way that maybe that's not a huge sales point to them, but it doesn't mean that we can't structure it to just build that in, right? So.
Yeah. So we have 5 minutes left. And I think we were going to talk a little bit about alliance updates and some business, but I'm kind of thinking we should just maybe do that via email. You know, so we're going to talk about the goals of 2023. We don't have a huge number of alliance members on this call, although maybe we have some future ones here. So I don't know. I think if you guys want to just keep the conversation going, I'm going to just kind of skip that last bit and do it via email.
So, you know, what I think is common for me now, that we need to work towards some sort of convene the key stakeholders. And that's in our work plan. I just want to put it on everyone's radar. You know, you will get communication, everyone who was on this call, about future steps. And that's what we need to do, right? I think like we need to be in one room and have more time. So we're not rushed, and we really talk through all the details of who knows what and where we are now and where could we take it, how could we combine all of it. So stay tuned. It's just the beginning.
Yeah, we should probably mention, yes, I thought about that earlier. Sustainable Solano has some funding right now to work on medically tailored meal vision, stakeholder convening, putting together an action plan within the next year or so. So it's more to come, I guess. Yeah, we'll be reaching out.